मॅडम YouTube लाईव्ह झालं आहे, आता रेकॉर्डिंग करायचंय. मॅडम को होस्ट करून टाका मला. आणि
अर्चना मलाही को होस्ट कर. Indrajit, you can start.
Okay, ma'am. Good afternoon, everyone. First of all, regards to all seniors and colleagues. Since this week we observe World Thalassemia Day on the 8th of May, as a part of our regular Palghar Academy of Pediatric weekly webinar series, we will be having a talk on hemophilia and thalassemia. So for this we have our esteemed speakers. We have two esteemed speakers speaking today on thalassemia and hemophilia. They are Dr. Ruchina Mishra and Dr. Amit Jain. So we will be starting first with Dr. Ruchina Mishra. She will be speaking on thalassemia today. And I would like to introduce ma'am. Ma'am, can you hear me properly?
Yes. Yes.
So I am introducing Dr. Ruchina Mishra ma'am. Her education, madam has done MBBS from Kanpur and DCH from Meerut. She has done her DND Pediatrics in 2004 from Bombay Institute of Medical Sciences, Mumbai. Madam has also done a fellowship in pediatric hemato-oncology from Royal Children's Hospital, Brisbane in 2007 and Royal Children's Hospital, Melbourne, Australia in 2008. She has also done a fellowship in pediatric bone marrow transplantation from Children's Hospital, Sydney. Ma'am has added another feather to her cap by doing an MBA HCA from FMS, Delhi. At present, Madam is a senior consultant of pediatric hematology, oncology, and bone marrow transplant unit at SRCC Children's Hospital. I would like to request ma'am to please start her talk.
Thank you, Dr. Indrajit. That was a lovely introduction. I really don't deserve all that, but you're kind. So I will start my presentation, and the topic that I've been chosen to speak on today is thalassemia. We're calling it Be Aware, Share, and Care for those with thalassemia. So this is my favorite slide because that's what it tells: eradicate thalassemia. And if I could have a magic wand, I would probably do that as well. Whatsoever it took, I would try and eradicate this disease as well. We are all very scared about cancer, but I think the children who get thalassemia have a more morbid life than those who are undergoing chemotherapy. Because even with cancer, we always have that hope of cure at the end of the treatment that we offer them. Whereas with thalassemia, we know that unless we do something very drastic, they're kind of destined to have a life that's full of morbidity. Initially, maybe not that much, but later on, the number of problems that these children get as adults is too many, and a lot of them may not actually live in to see how what old age will actually be like. And the oldest thalassemic that I have come across is about 42 years of age at the moment. So we all know that India is part of the thalassemia belt of the world, and as you can see in the world, the orange colored area is the thalassemia belt of the world. And quite a lot of Indians do have thalassemia. Either they may have thalassemia trait, which is not actually the disease itself, but they carry the genes of the disease and they are likely to transmit it to their children, or they may actually also develop disease as part of their childhood disorder as well. So what is the burden in India? The estimates indicate that there are at least about 1 lakh patients with beta thalassemia syndrome and at least about 1.5 lakh cases of sickle cell anemia within the country itself. There is an absence of national registries, so this number may actually not be the true number that is reflected, and there may be more than what is being counted out at the moment. But what we say is there are generally about 50,000 children being born every year with thalassemia major. And so in India, the kind of prevalence that is estimated by this March of Dimes Global Report on Birth Defects, it is estimated to be at least about 1.2 per 1,000 live births. And with a country which has a very young population like ours, we would have a whole number of cases that are going to be suffering from this disorder itself. So we all know as pediatricians what thalassemia is about. So I'm actually not going into details of that. We know that most of these cases are actually picked up at around 6 to 9 months of age when they come in for needing transfusions because they're appearing very pale. They have hepatosplenomegaly, and when you look at the child, you can, in some cases, in older children, you can find frontal bossing. You can find this extramedullary hematopoiesis, evidence of extramedullary hematopoiesis already ongoing. And then you realize that they have an ongoing need for blood transfusion. So just one odd blood transfusion is not good enough. They need repeated transfusions over periods of time. So how do we actually control thalassemia, and what would be the first step to get across this eradicate thalassemia program, or this desire or dream that we have, is to create awareness. That would be the first thing that we have. And this awareness needs to be created not only in the communities that are affected by thalassemia, but also in the general population as well. And also within the pediatricians or the practicing obstetricians and gynecologists as well, and GPs, I think, especially, because most people will actually go to their GP first before going to any specialist, no matter what we can tell them. But their trust lies in the GP, and that's their soul's kind of person who will either corroborate what we've said, or even one word of what they've said will go against anything and everything we might be trying to tell them about thalassemia as well. So what they actually find out, and this is an ICMR study that was done, that even in the highly affected areas of communities, the awareness is only about 39%. Only 10% of the population, that's the high-risk population, knows that a normal person who's never needed a blood transfusion could actually be a carrier for this disease. So CAP is a knowledge awareness a study that showed that only 10% of the population knows that even though you're normal, you've never needed a transfusion, you could be a thalassemia trait per se. And that's why this need to create an awareness. And how can we do that is by creating awareness at senior school level. I think the moment you reach adolescence is when you actually need to create this awareness about thals. Our younger generation is far more advanced than we are, far more learned than we are. And if they get this knowledge about thalassemia, how it happens, how it's kind of transmitted into the next generation, I think that's the key to try and prevent it from happening. So prevent marriages between thalassemia traits, or if you are a thal trait, to go in for the right diagnosis before you plan your pregnancies is all that. Another way that we could actually prevent or kind of create this awareness is through plays, through television documentaries, through social media messages, or using our politicians and actors to create awareness and spread messages between programs, between the TV programs. I mean, Amitabh Bachchan's done a great job for Pulse Polio, and he himself is a thal minor. So if he could pick up this and start talking about thal traits, being a thal trait, and the need to do their electrophoresis or do their testing prior to marriage, these would be the things that would work to create the awareness in our population as well. The government of India is actually doing a lot of work. And as I said, through this study that I found on the ICMR, there are a lot of programs that are run by ICMR to look at thalassemia awareness programs. So there's a Jai Vigyan program by the ICMR on community control of thalassemia. It's run in medical colleges of Maharashtra, Gujarat, West Bengal, Karnataka, Punjab, and Assam. And the intention was to screen college students and pregnant women initially, and they picked up a lot. They found that the incidence was almost about 10% in the population that they have surveyed, and they've done this testing, electrophoresis testing on all these people. About 10% of them actually had THAL traits present. In their second phase, they were now going to offer prenatal diagnosis, but that was a challenge that they were facing, how to offer it and set up the centers. But this is what this program is wanting to take on next as a program. The West Bengal Thalassemia Control Program has already set up 2 nodal centers with about 21 centers in different districts for awareness, screening, and counseling. And there they found that the range of thalassemia is between 4 to 10%. And they've also developed a program, a software program called Thalman, to kind of create the records and maintain these records for screening of these large populations. Gujarat state has also got something very similar. So it has made thalassemia screening compulsory in colleges, and they're very, very proactive about it. The Red Cross is helping them with this screening program in the colleges and the schools, and they're offering antenatal screening and prenatal diagnosis in Ahmedabad, Vadodara, Rajkot, and Bhavnagar already. And they're hoping that they might be able to expand it a little more as time goes on. So Maharashtra also took up a pilot study for screening, prevention, and treatment of existing patients with thalassemia and sickle cell. They first took it up in Thane, Nashik, Satara, and Amravati because that's the major belt for Maharashtra. And now they're going to try and extend it to other regions. And Punjab is also following up with a project Rainbow, where state and central government with different NGOs and parents will work together to take care of the thalassemics in Punjab. We all know that all thalassemics through the Thalassemia Federation should be offered free blood, but I don't think that that is enough. What is actually needed is this screening program to try and prevent more births from happening, and also to have a good chelation program, good transfusion program, as well as a good chelation program to try and get this disease under control. So which communities are at risk where we see that there is an increased burden? It's basically the Sindhis, the Lohanas, the Bhanushalis. It also in Gujarat, we have the Konkana tribes in Surat and South Gujarat, and the Bhuiya, Pik, and Dund tribes from Sundargarh, Odisha, and the Rohit tribes from Surat, which have a high incidence of thalassemia present. And similarly, Maharashtra also, our area where we have Raipur, Chhattisgarh area, that area is also a big belt for sickle and for thals as well. So how do you screen for thalassemia majors? So this is generally just an algorithm to help people. The Nestroff test was actually the original test that was done, which Dr. Anjali mentioned initially, which is the naked eye test to look at the osmotic fragility and try and pick up the THAL traits on that. But nowadays, we generally try and use the RBC indices and HPLC to pick up a THAL trait. If you find that their MCV is high and their MCH is high, which is more than 80 and more than 27 picograms, and your RBC count is normal, the RDW, which is also given by your Coulter reading itself, if that is normal, and your HB electrophoresis shows an HbA2 level that's less than 3.5, then this is absolutely normal. But if your HbA2 level is more than 3.5 and you have a microcytic hypochromic picture with an increased RBC count with a normal RDW, then this is a THAL trait. However, if this patient had got a high RBC count and a high RDW, then this child, an RDW that's sitting by about 14, then you would be thinking of a thalassemia major in this patient. Again, if you have microcytic hypochromic anemia, normal RBC, normal red cell distribution with an increased RBC count, but in HbA2 that's less than 3.5, then either this is a silent beta thalassemia not requiring a lot of transfusion or maybe irregular transfusions, or this could also be an alpha thalassemia or a delta thalassemia. Very rarely do we see, but recently we've just picked up an alpha thalassemia carrier who actually was absolutely normal with the hemoglobin sitting at around 12.8, 28-year-old male, never having needed any blood transfusions, and he elected to be a donor for one of our patients. But because of these parameters, the apheresis center was very worried about it, and they asked for genetic testing for this kid, and it turned out that this 28-year-old man was an alpha thalassemia carrier. Makes no difference because he's a carrier. It doesn't impact his lifestyle or the ability for him to donate, and we've used him as a donor. But this is just for normal people's information that there could be people around who could be carriers as well. Normally, if we find a high RDW, and this is something that we tell everybody, if your RDW is more than 14, then that actually goes towards iron deficiency anemia. But you could have a beta thal with an iron deficiency anemia, but treat the iron deficiency anemia and you will see that this is a thal trait or not. Sorry. And then you could have some other variants that would be picked up by the electrophoresis itself. So how would we treat our thalassemia patients? We're generally trying to recommend that all of them get some kind of mutation analysis and an XMN polymorphism. The reason why we ask for an XMN polymorphism is that some of our thal kids were the actual thal intermediates. Now, when we're talking about thalassemia, we talk about thalassemia minor and thalassemia major as the two major criteria that we have. Sorry. But we also know that there is one category of patients who may not require regular blood transfusions initially, but as their growth goes on and when they reach the growth spurt, that's when they start needing a lot of blood transfusions. This is the group that we refer to as thal intermediates. This group of thal intermediates don't require upfront regular transfusions. They're kind of able to maintain with a lower transfusion requirement, but soon they will come a stage when they will need transfusions regularly. And these are the ones that have the XMN polymorphism. And if we can give them hydroxyurea, then their transfusion requirements actually decrease even more. So this group may benefit from hydroxyurea therapy, which will delay their transfusions and therefore delay the iron overload in their system for quite some time. The mutation analysis just helps to identify the mutation that is present. And so we can actually counsel them regarding their next genetic testing and the next pregnancies as well. The intention is that they should get regular blood transfusions with the aim to keep their HP greater than 9 at all times. So their pre-transfusion HP should be greater than 9. So those centers that are offering PRBC transfusions should do this when they're actually pricking the child to get the cross-match sample. There is no need to actually do a repeat check after the blood has been given. So there's no need for a post-transfusion check for our thals. Just do a pre-transfusion check, and if you're finding that your pre-transfusion values are going less than 9, please advocate sooner transfusion. So instead of coming 3 to 4 weekly, they should start coming 2 to 3 weekly at that stage. Some of them may require a bigger volume that needs to be given to them. The volume that we generally choose is 15 ml per kg. That is to be transfused to them over 3 to 4 hours. It's a normal practice with all blood transfusions that you should try and avoid transfusions beyond 4 hours because it increases the risk of bacterial sepsis within that blood unit. So try and finish the transfusion within 4 hours. Now, if he needs 2 units of blood, that can actually be finished within 4 hours, provided that child doesn't have any cardiac dysfunction present. So the 2 bags can also go within 4 hours itself. Please use NAT-tested irradiated blood if possible, whenever available. If not available, then leukodepleted products with the bedside leukodepletion filters to be used. There's a lot of confusion about whether to use 1 filter or 2 filters. It generally said that you use the double filter if you're giving more than 1 unit of blood. If you're giving just 1 unit of blood, you use the single filter. That should be good enough. Transplanters will always tell you that please do not use blood products from first-degree relatives. If you're planning to transplant this child at any stage, him or her developing antibodies will become a problem for us. And if you're planning for a haploidentical transplant sometimes later, then these can be problematic in terms of the acceptance of the graft. So try and avoid blood products from first degree relatives. Chelation should be started once your ferritin is more than 1000 nanograms per liter. And the reason is that we don't want iron overload to come in. The children who are regularly transfused, who do not have hepatomegaly and are on good chelation therapy, do very well with transplants. But if any of these three parameters is not met, then transplant can sometimes be a horror story as well for some of us. So we really want them to be on good and appropriate chelation therapy once their ferritin is over 1000, and try and keep it around 1000. The lower, the better it is for us. Also, these children will need some of the multi-speciality care after they're about 5 to 8 years of life. So once they've crossed 5 years, we start asking them to have off-thal evaluations. We start looking at their bone densities once they're about 8 to 10 years of age. We start getting endocrinology follow-ups for them, hepatology follow-ups for them. Once in a year, we ask them to get their triple H done, that is the HIV, hepatitis B, and HCV, because they're getting blood products. Previously, a lot of these kids used to either get HIV or get Hep C with them, which was again a nightmare for many for treating them. Now with better drugs, with the liver team that is present, Hep C is also very, very curable. But they will need to be monitored proactively that they don't get these diseases and they don't land up with chronic liver failure in these patients. So as pediatricians, this is what the expectation is, that when you're thinking about optimal care for a thalassemic, that you would be looking at all these factors in when doing the transfusions. What I haven't actually put in there is mental health, and that also is a very big factor. A lot of our kids, because of the chronic need of coming into hospitals very frequently, are depressed. They're depressed because they're short statured, they're being bullied at school. So these factors also need to be considered. The endocrinology referral often goes in because they are short statured and they're reaching puberty, so they need growth hormones to push their growth spurt at that time. So we will have to offer them holistic care if you're thinking about offering care to our thalassemics that are there. The next is about chelation therapy. So there are a lot of drugs that are available for chelation therapy. Desferoxamine was the original gold standard that all of us know about. When I was doing my training, we only had desferoxamine, and all these children would come to the daycare center, get their IV put in there using these subcutaneous injections for thalassemic, and they would come get their transfusions and show me all those nodules that they developed with their abdomen because of the chronic injections that they were getting for desferal. But we've moved on from them. Treatment is now easier because we have a lot of oral iron chelators available. We have deferriprone or Kelfer that is commonly used, supplied by Cipla in most cases. The dose is generally about 75 milligrams per kg per day. And we give this as 3 divided doses to these children. Usually, again, we say that try and take it on an empty stomach, and try and take it either with orange juice or some citrus fruit. Avoid tea or milk or an immediate food intake around the time that you take the medication, because all this will hamper the absorption of the drug that is there. Now, deferriprone also makes your urine turn red. So a lot of children who are on deferriprone, they will complain that they're passing red colored urine. Please don't be scandalized by it. It's just because of the drug that they are getting. When I was doing my residency, I sent quite a few urine samples trying to look for blood in the urine, and then being surprised that there was nothing there there. The more common drugs that we are using now is Deferazirox, or it's also called Asundra, Deferijet, Deseriox. They comes by different names, different companies are making it. The usual dose is between 25 to 30 milligrams per kg per day. We give it as a once daily dose, so early morning, empty stomach, stomach is when you need to take it. Again, the same thing, try and take it without food. Try and take it either with some plain water or with some citrus vitamin C, but try and avoid everything else around it as well. And then there's Oleptis present in the market as well, which is the Deferrizerox Advanced, which is also supposed to be very good, but frightfully expensive for our patients. So I haven't actually prescribed it to anyone as yet. It's supposed to be a dispersible tablet, so not so difficult to take either. And in the newer advances, we have luspatercept. Luspatercept is actually an activin receptor ligand trap that's been shown to enhance the late stage erythropoiesis in animal models of beta thalassemia. It's actually approved only for adults at the moment. There was a phase 3 trial called Believe trial that was carried out in adults, where this injection was given subcutaneously twice a week. And this showed that their transfusion requirements went down and their ferritin levels also came down quite quickly with this drug. So it's at the moment it's advocated or approved for use only in adults. Hopefully we'll see it being approved for pediatrics very soon as well. So that's it. The only disadvantage is that it's given subcutaneously at the moment, but otherwise it's supposed to be a very effective drug. But what actually works for them? I mean, this is all therapy that's kind of trying to elevate their morbidity. What is the curative treatment for thalassemia? And there's only one curative treatment at the moment, and that is bone marrow transplants for them. Now, bone marrow transplants, the best transplant that you can offer is a matched sibling donor transplant for our kids. With matched sibling transplants, we've actually seen that the overall survival is as good as 93% in our patients. The transfusion-free survivals may be between 80 to 90%. So it's really good if you have a matched sibling who's a match. Please don't hesitate, try and get them transplanted as soon as possible. Most transplanters will recommend that you get your transplant done between 2 to 8 years of age. And the reason for that is that by about 2 years, the child is able to verbalize. So we can interact better with the child. There is no contraindication to doing a transplant earlier also. My youngest transplant for thalassemia has been somebody with an O Bombay blood group, and we transfused this kid at around 9 months of age because this kid was in Australia, and finding an O Bombay blood group compatible with this child was very, very difficult in Australia. So we transplanted him with a mud donor. Again, the donor was from India itself. And this kid was just 9 months old when we transplanted him. So actually, there's no contraindication to an earlier transplant. The reason why we choose 2 years is just so that we can interact better with the kid at that time. The risk of rejection, the risk of GVHD, and the transplant-related mortality is very low with matched sibling donor transplants. So if there's one message across that needs to go across, is that matched sibling donor transplants are pretty safe and should be advocated in all. The next is matched unrelated donor transplants, which means that we find a donor who's not from the family, but someone who's altruistically decided that they'll donate their stem cells for anybody who needs it, provided the HLA matches. And they found that the results are almost as good as a matched sibling donor transplant. So your survival rates with a bone marrow transplant or even a cord blood transplant generally are between 80 to 85% with a matched unrelated donor as well. We need to monitor them a little more carefully later on, and their risk of GVHD is slightly more as compared to the matched sibling donor transplants, but the overall survivals remain the same. So matched sibling and matched unrelated donor transplants should be done as much as we can, as soon as we can find it for you. Then, and this is the same thing, related and unrelated bone marrow transplants of beta thalassemias. An international survey that was done by the EBMT group that actually by the Americans, that actually showed that the differences, there were very, very few. So the blue line is your matched relative, which is about 86% with children who are less than 8 years of age, the blue line over here. And your matched unrelated donor transplants is about 82%. So not that bad itself. If you had a mismatched unrelated donor, then that did badly, and a mismatched relative did the worst. But still, 70% is what the cure figures are. So still very, very good in terms of actual overall survival and curability of the disease as well. So haploidentical transplants is what we are talking about now. In India, we have a very small registry that actually gives you the opportunity to find a mud donor. The largest registry in India is Datri. Datri has just about 4 or 5 lakh donors that are registered on Datri at the moment. So for a population as big as that of India, if you only have 4 to 5 donors, 4 to 5 lakh donors, the chances that you'll find a match in that registry is also pretty small. But still they're doing quite a lot of transplants and they're being able to find their matches. So we need to expand on this registry. But even then, about 50% of our children will not be able to find a match, be it in the family or be it outside the family. And there's where haploidentical transplants comes into the picture. Initial haploidentical transplants had a very high risk of graft rejection and GVHD. So a lot of physicians are very wary of this because of that initial rejection and GVHD that we saw, and we lost our patients to that. But now we're doing very specialized kind of transplants, and Mumbai also has those facilities available. So what we're offering them is something called a TCR alpha beta depleted CD45RA depleted transplant. And in this, what means basically, the gist is that the cells that we need, the CD34 positive stem cells that we need, we give them a very high number of that. But the cells that actually cause problems, the T cells that can cause problems in terms of rejection and in terms of GVHD, we try and manipulate to try and give a very minuscule amount of that. So that kind of helps the child in getting what he needs, but taking away what he doesn't really need. We've done about 14 transplants till date at SRCC, and luckily for us, all the 14 that we've transplanted for thalassemia have done very well. We've not had a single mortality in that so far. And we also see very quick immune recovery happening in these patients, because we can offer them what is called donor lymphocyte infusions, or we can offer them their memory cells back to them, because the manipulation gives us these cells in a separate bag, so we can give them the immune recovery faster as well to these patients. So this is the way forward for us. When we've done haploidentical transplants for hemoglobinopathies, the paper says that their overall survivals are about 84%, which is about the same. 86% was what we were talking about match sibling donor transplants. 84% is also about the same when you're doing a TCR alpha beta depleted CD45RA depleted transplant, with a disease-free survival of about 70% for these patients. Yes, our graft failure rates are a little higher and we are still working on them, but if you're able to give them bigger doses of CD34, then this will also decrease over time as well. And also the kind of conditioning that we are using, we've got newer drugs that are available now, where we are decreasing the complications that we are seeing with transplants. Now, Amit and I will tell you that veno-occlusive disease is a very dreaded complication that we find in our thalassemics who are not very well chelated. So a class 3 thalassemia, a class 3 thalassemic is somebody who's not well transfused, not well chelated, and has hepatosplenomegaly or already has undergone splenectomy at some stage. We dread these kind of patients because they have a very high risk of veno-occlusive disease, which means the liver starts getting small clots post the conditioning therapy that we give them for the transplant. And that actually can become a reason why we have a mortality during transplant. So there are now drugs that are coming up where this can be decreased. So triosulfan instead of busulfan being used for these protocols, where we know that these patients are high risk for us. Sometimes using a reduced intensity conditioning regimen may also work, but we know that this may have higher failure rate as well. And then trying and doing this TCR alpha beta depleted CD45RA depleted transplant would actually benefit these patients as well. So that's one of the protocols that was followed. And this is supposed to have very good survivals. This is from Thailand. This is a paper by the Thailand group, which has been quoted everywhere, and which is the reason why we are picking up on transplants, haploidentical transplants. They could show that their survivals were as good as 90%. Most centers have not been able to replicate it, but we still have pretty good survivals with this kind of regimen that we are following. So that's what the future, I think, holds, that haploidentical transplants will increase over time. Yes, we will kind of tweak the conditioning regimen and we'll tweak the immunosuppression a bit so that we can try and get the best of all the worlds that we can offer to our kids. What we are doing right now is we do offer them some kind of preconditioning chemotherapy and then do the transplant and follow it up with post-transplant immunosuppression for some time. So that actually helps. There are a few late effects that we often see with our transplants, and that is something we cannot miss. So there are some complications that are there. Our kids, even after transplants, will need to continue to have some kind of monitoring that is needed, especially in terms of hormones. So thyroid complications, both hypo and hyperthyroidism is quite prevalent. We also see a lot of nodules, thyroid nodules coming in. We do see diabetes developing in our children, and sometimes they end up with cardiac failure as well. So they will need to have continued monitoring. We will also need to continue to monitor them once they reach puberty, because that is something that we're transplanting at a younger age, and we need to ensure that they do reach puberty appropriately, and they may need some kind of testosterone or other hormonal supplementation as well. We always tell our patients that right now, with whatever modality of treatment that we have available with them, we're going to make them infertile. That means that they will not be able to have their own kids. They will mature to be normal adults. They will be able to have a married life, but they may not be able to have their own kids. But having said that, there are other ways of having kids as well. You could use IVF, you could use some other form of zinc fertilization, or you could also adopt a child if you wanted to. Those facilities are still available. The important thing is for them to be able to have a healthy life when they want to have children at that stage. So, but they will need to have kind of continued monitoring that is still available. There are a lot of studies that have gone on to kind of look into the late effects post-transplant for our patients as well. And we have been successful in reporting some pregnancies that have still happened post-transplant, but these numbers are a little less at the moment. A lot of us we need to monitor our kids for premature ovarian failure as well once they become sick. But even then, the success stories that we come across, they are fantastic. We love to see it. This child in the center that I transplanted at Medanta about 7 years now is an MBBS doctor, passed out from Manipal, and is now planning to do pediatrics, is what he tells me. But let's see if he can get through his post-graduation exams. This boy was one of the first transplants we did at SRCC. He's now 17 years of age. He's very, very active outside. He's recently finished some marathon, and he's very good at rappelling and mountain climbing, and that's where his interest is. And he says, that's what I want to be. I want to be a marathon runner, is what he's working on. And this little girl, one of my favorites that I have, passed through transplant, haploidentical transplant, but just breezed through it because she had such a positive outlook to life that I always put a picture there and tell everyone that if you are positive in your thinking, you can get through everything possible. A lot of people ask us, and this is my second last slide that I have, I don't have thalassemia, but how can I help? So there are a number of ways that you could help. Be a blood donor is the simplest way. We need blood. We don't have blood available. And especially during COVID, there was a lot of problem for these patients to get blood appropriately at the right time, and a lot of transfusions were delayed because of non-availability of blood. So if you can become a regular blood donor, that would be so helpful for us. Or you could regular to be a stem cell donor as well. As I said, there is a big need to have more and more stem cell donors for the matched unrelated donor transplant programs that we want to run. So please register and do that as well. And thank you so much for your attention. I will stop there. Thanks a lot for your kind hearing.
Thank you, ma'am. Thank you for such an excellent lecture and in-depth information which we received on transplant. Ma'am, I had a question for you. If you can take it now.
Sure.
Yeah, ma'am, I wanted to know about prenatal diagnosis and counseling for thalassemia.
So once we have diagnosed somebody with thalassemia, we always offer prenatal testing to them. What is normally said is that you do a chorionic villus sampling, which is generally done between 10 to 12 weeks of gestation. So you do the HPLC of the embryo at that time to see whether that child has got thalassemia major or not. There is a small risk of failure in those patients because sometimes you get the maternal blood and not the patient's, the fetus's blood in that. But that is something that is advocated to all if you know that there is a family history of thalassemia that is present. And in some cases, we're also looking at pre-implantation genetics. Before you actually implant the fetus, if you can look at doing the testing of that fetus to decide that you're not going to implant an embryo that has thalassemia in it, the thalassemia mutation present in it, then that can be done as well.
Okay, ma'am. Anybody else? Any questions?
Yes, Ruchira.
Yes, ma'am.
Recently diagnosis. Okay, we have two devices. Not.
Ruchira, your patient, that was Arushi, who was your favorite patient.
Yeah. Yes, ma'am.
She's
She is
so
such a-
positive.
Yes, she is just so positive in life. It's brilliant to see the whole family come in every time.
Yes.
Madam, can I ask one question?
Yes, ma'am.
Yeah, there are pockets in this Palghar district also where we see sickle cell patients or thalassemia patient also. So, is there any like in Thane, Amravati or these areas where Satara and all have this ICMR project going on? Do we also have the project going at Palghar district?
Ma'am, I'll have to find out about it. I'm actually I'll have to, this is something that I picked up from the article. I will find out that it's actually happening and where it is happening in these districts. I will find out about that and I'll get back to you on that.
Yeah, Ruchira, can you please play that slide where you have written about the ICMR study?
Yeah.
I have taken one snap. Maybe
Okay,
share
fine.
it.
Okay, I'll share it.
I'll
Jaishri
share.
will share it with us.
Yeah, definitely.
Yeah. Yeah, and Ruchira, I wanted to ask you that often we depend upon this, RBC count. Most often we get a very high RBC count. I don't know whether that is reliable and the indices are reliable, and that whether we need to do an HB electrophoresis of every child. Because I think there is a national guideline which says that all adolescents have to be screened for thalassemia and sickle between the age of 13 and 15. So whether this is something doable or...
Ma'am, so the guidelines, yes, they do suggest, but I don't think that that's practically possible doing it right now. But we look at the indices. So if you have a microcytic hypochromic picture, if you have your RDW that's less than 14, then yes, you think about doing the HP electrophoresis for these children. But if your RDW is more than 14, then first treat them with iron supplementation and see that microcytic hypochromic anemia improves, and then decide about the HPLC later on. So
yeah, because they will be going in for pregnancy and then we lose on follow-up. So I don't know whether...
But it is definitely advocated that if they're planning a pregnancy, their obs and gynae person should get their HP electrophoresis done as part of their workup at that time, because that is definitely recommended. In fact, my teacher used to tell me in Delhi, he said he used to tell all his students कि तुम जन्म पत्री मत मिलवाना, तुम प्लीज HP electrophoresis करके HP electrophoresis की रिपोर्ट देख लो कि वो मिलती है कि नहीं मिलती है. He was so anti a janam patri. He said, rather than look at that, look at your HB electrophoresis report. So he would push it for everyone that please get an HB electrophoresis done. But as you rightly said, that doing an HB electrophoresis for everyone may be a little out of pocket expense for them. May not
because
be very...
I believe that all the districts have been given machines to do the HPLC, and they are able to do even 150 tests per day. So every district has one. I am trying to find where Palghar district has it, because I think the Maharashtra IAP project this time to eliminate thal and sickle. That is this.
That is the yes, and that is what the aim is, to try and do.
Eliminate
Again, we have to find out how practically is it it being done? Is it only on paper? Is it actually being implemented? So which centers we are
Exactly.
doing, we will have to take.
Palghar district has not yet started with HPLC. It is yet
But
to
that-
come.
Yeah.
It is yet to come.
Yeah, so we have to try and push for it, because every district is supposed to have 2 machines which are dedicated to do HPLC for thal and sickle. So I think it's
They do
Where?
at Palghar. They do
Where?
at Palghar.
at
At
Palghar.
Palghar. Yeah.
Oh.
From even Dahanu, they collect the samples and they get it done.
Okay.
सर ते आता जे जात आहेत ते ठाण्याला जातात. आपल्याकडे पालघर डिस्ट्रिक्टला अजून आलेलं नाहीये.
No, listen to what Jagdish is saying. He knows that it's done at Palghar.
Yeah. We are getting HPLC reports from Cottage Hospital. Yeah.
Superb. So I think even Dahanu Cottage Hospital has, Jawhar Cottage Hospital has.
Yeah. Jawhar also has that.
Yes. So they are having this, they do free testing for all their residents. So they just have to go and walk in for HPLC. But
Yeah.
this is something we have to work on and try and get it, because it's something different that we send for bone marrow transplant, but we have to try and eliminate and detect these patients. So that is the whole idea.
I wanted to ask Ruchira, how long would you like to give oral iron trial for thalassemia minors or even sickle cell also? Because
So the recommendation is that you give them iron for a week and you should see an increment in their HB within the week itself, sir.
would it not be better to have iron studies instead?
You can do, sir, if you can afford an iron study, you can afford an HPLC then.
Yeah, I think what we need to do is every child of anemia, we should do HB electrophoresis. Jagdish, we were just thinking that every child of anemia, we should do HB electrophoresis. And if that is normal, then give iron.
No, the indices are suggestive, then we should go ahead with HPL electrophoresis, you know?
If you have a microcytic hypochromic anemia and you have your RDW that is low and your RBC is increased, yes, and you have the facility for an HPLC, please go ahead and do it. If you have a restriction over there and you find that your RDW is high, so your RDW is more than 14, then you can give them a trial for iron and you should see an increment of 1 gram within 1 week itself, sir. So if you're not seeing that within 1 gram, then yes, you will need to do your HB electrophoresis also.
1 gram within 1 week.
Within 1 week, your HB jumps up by 1, sir.
Okay. And I wanted to ask something. Would you like to repeat those parameters for alpha thalassemia on indices?
Yeah, so the alpha thalassemia will have an increased red cell numbers. So your red cell numbers will be increased, but your RDW will be normal in these patients, and your HB electrophoresis.
HbA2 will be less than 1.5.
Yeah.
Which one? HB?
A2.
A2 will be less than 1.5.
In beta thal, you would have it in thal.
More than 3.5, yeah.
More than 3.5. In alpha thal, you will have it less than 1.5.
Ruchira, I like your dream. Eradicate thalassemia.
Yes. One day we will there, ma'am. We will reach there. I'm reading a book called Secrets.
Oh.
I think everybody's already read it. I'm a late starter, and I think you can manifest your dreams. So
Ruchira, one more thing, we want, so now we are perhaps past the age when we can be stem cell donors, but we'd like our kids to be. So can you guide us how Dhatri, I think I asked you this earlier also, how we can ask Dhatri or whoever that NGO is who is working on this, then we can, and if it's possible to start a registry for thal and sickle.
So yes, the registry for thal and sickle, most of the thalassemia federations or the thalassemia societies are already doing it. But in terms of registering as a donor, whenever we run a donor drive, I will contact you when we do that. And if they can come to that center, then we will send their samples across as well.
Yes.
I am actually hoping that SRCC will actually run a donor drive for Thalassemia Day that's coming up.
I think 8th is coming up as a thal day. If we can run a donor drive on that day, we can refer a lot of kids to you.
Yes. So then we can do that as donors, not as patients, but as donors.
No, as donors.
As donors,
Donors
yes.
yes, to register as
So
donors.
if that finalizes, I'm still trying to talk to Datri to do this, because being an NGO, they need funds for it, and I'm pushing to do it free. So if I can get that approval in the next couple of days, I will message you all to say that in case there are, then we would like to see you at SRCC on the 9th.
Yeah.
Yeah.
Thank you so much. And another thing is that would RBC indices miss sickle cell anemia?
Sometimes, very rarely, sometimes, because sickle may not actually be picked up. Sickle is picked up when you have an actual sickling crisis. They may not actually pick up sickle just by the indices itself.
But can you suspect double heterozygous on indices?
Sorry, sir.
Double heterozygous, like carrier alpha and beta and sickle.
Yeah.
Indices.
Yeah. So we do see some, then like a beta sickle thal, or we see HB beta E, kind of those patients, we do see that. And it's the electrophoresis that picks it up then. When you
No, but on indices, can you suspect anything?
No.
No.
I think that there is some thalassemia syndrome, but you don't really pick it up on just based on the indices. No.
We have a practical problem, Ruchira,
Yes, sir.
regarding blood transfusion in a patients of thalassemia.
Sir.
Because we don't get triple saline wash pack cells over here, as well as when we try to transfuse, we have to use leukocyte filter, which is costing somewhere around 2,000 rupees. Transportation of patients, when they become big, it's become very difficult for them to transport patients to either Borivali or any other big hospitals, and then they don't get blood at that particular time of the day or something like that happens. So we have tried to mobilize some facilities at local level, but we are not yet successful in trying to establish a blood bank which is capable of doing triple saline wash or irradiated RBCs. So if at all, this is very big if SRCC is planning, or if helps us out in establishing a peripheral center out of some NGOs or something, and if we can, in a joint venture with our local blood bank or establishing a new blood bank, and if we try to do something for this thalassemia patient, it will be of very great help.
So we are in the process. So what we're looking at is trying to, because we do have a blood bank already functional at SRCC. We are trying this again. We are also facing a financial crunch right now, and we're not being able to roll it out right now. But we are looking at trying to set up a thalassemia facility over here itself at SRCC. Once we can do that, then we can look at peripheral centers as well. I agree that blood and triple filters is a big problem, but as I said, sir, if you're getting it from the market, it will definitely be a problem. So what you should recommend is that the patient should get registered with the THAL societies that are there, because then they can get the filters at a subsidized rate.
Yeah.
How to register?
I will pass on the number for the Think Foundation, Mr. Shetty. I'll ask Mr. Shetty and I will pass on his number, ma'am. So he heads Think Foundation and we are in touch with him. He can help you and guide you through that, because they run very active centers. I also know a group of parents who registered or found a group to be able to donate blood quite regularly. So in case you're finding problems in getting blood, then these guys have formed a group. If you put it on that WhatsApp group, then they will come and donate. So we've recently had somebody who had O negative blood group and was finding it difficult, not from SRCC, but they reached out to SRCC and our social worker put it on the group. The next day, one of the parents went to the hospital where this child generally goes for a transfusion, donated blood so that he could get fresh blood. So that's how people are trying to kind of join hands and work together. So I will ask Sanjay, who's our social worker, also if he can give you contacts for those in Palghar area as well. We'll do that.
Yeah, so Maha IAP is running a program starting on the 8th till the 19th of June, which happens to be Sickle Cell Day. Amit, we'll just take 1 or 2 minutes more. So Maha IP is trying to run this program, and they are planning to, spread message, send WhatsApp messages, send a lot of this to the Foxy, to gynecologists to include that in their screening, to neonatologists to do neonatal screening, as well as talk to adolescents and colleges. So as part of this Thal and sickle thing, what Shailesh has in mind is a very good idea. We as a group of Palghar IAP, I think we should take the lead and start a Thal support group, and perhaps we can have a common WhatsApp group for those who have Thal, and then these contacts, like she said, help them to register with Mr. Shetty, or a blood bank which will give them the blood which they need. So if you like the idea, Shailesh, we can launch that on the 8th.
I am trying to establish a blood bank itself over here in Palghar with triple saline wash and irradiation facility.
So I think
And
we'll set up a blood bank.
my dream is that another 5 years down the line, I'm definitely trying to do that. And I'm
Very
going
nice.
to do that. 100%.
Yeah, so in the meantime, there is already a blood bank. So if we can speak with them, Sarla Blood Bank, I can talk with them, and we can try and get them to irradiate or triple saline wash, so that so we don't need 5 years. We can perhaps start even soon. So I'll speak.
I am talking about irradiated. I have lost 2 babies who are 800, 700 grammer, became 1.5 kg, and we transfused them, and they got congenital rubella infection, and they died of that. And so if it is irradiated blood, then that blood borne infection does not occur. So that is the only
So
thing.
I'll speak with Dr. Neeta. You can go ahead with your dream, but in the meantime, in the early 5 years, I think I'll speak with Neeta and ask for, I'll get more details about what is the difference between triple saline, irradiated, NAT tested blood, so that we can help them with all of that. So
Sure, definitely.
do that. And I think BSES, that is Dr. Mamta Manglani's blood bank at Borivali, does give irradiated blood at cost. They give it, suppose you want irradiated blood, they charge you extra for that. So whatever the cost of the blood, plus 500 for that irradiation. She had told us last time when she had spoken. That is available. That's available at Borivali. So that facility is there.
Ma'am, it's free of cost, ma'am, for government, BMC and government.
Yeah, it's free for them. But if somebody from outside, she said that I will charge you for what is needed for the processing, and then she would give. So I think that facility is also there. So I think all these points we can bring, our thalassemia day, so that some of our patients can be benefited by that. Also, where to get these filters, like Madam was saying, double filter and all those things. So I think we can work on that. Yeah, very nice, Shailesh, for bringing up these points. And this Nestrov test, I think, was what Mamta ma'am was talking, that I think earlier they used to do the Nestrov test, which is just a naked eye examination test. And that was, like HB electrophoresis will cost us 900 rupees, but that Nestrov would be free of cost. So you just have to shake it or something. I think I'm not sure how it's done, but Amit perhaps can expand on that.
And ma'am, actually, Mr. Vinay Shetty is already in touch with Sarla and one of the blood bank in Nalasopar, ma'am.
Okay.
To establish blood transfusion center there, ma'am.
Okay, super. Because Sarla Blood Bank used to run it for some time, and then the madam has gone abroad. She has left. So then now they have stopped it, and they have transferred all their babies to Borivali. So if they can set up at Sarla, that will be amazing. And then perhaps we can speak to them about irradiated blood.
One last question for Ruchira ma'am from Dr. Joshi. What precautions does a thalassemia minor patient need to take to lead a near normal life?
Nothing. Absolutely normal life, ma'am. They shouldn't marry another thal minor. That's the only precaution.
Or if they marry, then not to have a baby
without the testing.
Or to
Prenatal
testing.
Prenatal diagnosis.
Prenatal diagnosis.
Otherwise, there is no restriction to life.
Yeah, nothing.
So how will we diagnose thal minor with iron deficiency?
And again, these children will present like an iron deficiency picture, but you wouldn't find that their HB will improve that much with the iron therapy that you give them. So that's when the HB electrophoresis will come into play, because that will pick up the thal trait.
Indrajit, I think we can go on to our next talk on hemophilia.
Nice presentation.
Very nice, Ruchira. Thank you so much.
So our next speaker is, moving on to our next esteemed speaker is Dr. Amit Jain. When can you hear me?
Yes, we can hear you.
Yeah, this is Dr. Amit Jain, and the next esteemed speaker who will be talking on hemophilia for us today. He is, I would like to just highlight a few points, sir's achievements. Sir has done MBBS from Gandhi Medical College, Bhopal, and he's done his MD Pediatrics from Sayan Hospital, Mumbai. He has also done a fellowship of pediatric hemato-oncology from Indian Academy of Pediatrics, center being MCGM Comprehensive Thalassemia Care, Pediatric Hemato-Oncology and DNT Center, Borivali, Mumbai. Yes, sir has done work there for 2 years and at present again as a consultant at the same place. And these are a few of his attachments. He is also at a Daffodil Group at Kandivali. Sir, also a few of his achievements which I would like to highlight on this slide. These are his few publications and a few poster presentations. And sir has also assisted in almost 100 bone marrow transplants. So over to Dr. Amit Jain, sir, for this talk.
Good afternoon, everyone. So thank you for giving me this opportunity. So as we all know that Hemophilia Day was on 17th of April, and the theme for this year was Access for All via partnership, policy and progress. So by creating awareness and bringing hemophilia and other bleeding disorders in attention of national policymakers, we can increase sustainable and equitable access to care and treatment. So there was saying in 2nd century, if a woman had her first son circumcised and he died, and she had second one circumcised and he died, she should not have third son circumcised. So the journey of hemophilia begins from there. So we'll begin with the case of bleeding after circumcision. 3-day-old child was shown to pediatrician following this, and three-day-old male was seen by a pediatrician following discharge from the hospital due to blood noted on the gauze covering the penis. He was circumcised at day of life 1. The child was full term, otherwise well, feeding well, passing stools normally. And on examination while removing gauze, there was significant bruising around the head of the penis. So there are certain questions that we should ask to the parents, if the child has received vitamin K or not, because vitamin K deficiency is the most common cause of bleeding in the most common cause of hemorrhagic disease of newborn. Along with that, family history, whether the family is there is significant history in family of abnormal bleeding or hemophilia. However, absence of family history does not necessarily mean patient does not have bleeding disorders. And most any change in behavior of the baby or size of it to rule out dreaded complication like intracranial bleed. So what should you do at this point? So there are certain points like we should do nothing and consider this as normal and reassure the parents that it will heal in a few days. Get a CBC, get CBC, PT, APTT, admit the child for further workup or call pediatric hemato-oncologist.
3, 4, 5.
Yeah, yes. So get CBC, PT, APTT, admit the child for further workup and call pediatric hemato-oncologist for advice. So we'll begin with a brief on hemophilia. So hemophilia is derived from 2 Greek words. Hemo means blood and philia means affection or liking for the blood. It is an inherited or acquired bleeding disorder because of deficiencies of clotting factors. Hemophilia is X-linked recessive disorder. Hemophilia A constitute 80 to 85%, while B constitute 15 to 20%. Hemophilia A is factor 8 deficiency, while B is factor 9 deficiency. The incidence of hemophilia A is 1 in 5,000, while B is 1 in 30,000. Usually family history is there, but 1/3 of the patients may not have any significant family history and they may get hemophilia by spontaneous or de novo mutation. So, like revision hemophilia is factor 8 deficiency and it is X-linked recessive. Hemophilia is factor 9 deficiency and X-linked recessive. Hemophilia C is factor 11 deficiency and it is transmitted as autosomal recessive, while parahemophilia is factor 5 deficiency and it is also autosomal recessive. Hemophilia C and parahemophilia is very rare. So moving to pathophysiology, the mechanism by which coagulation allows for hemostasis is an intricate process that involves series of clotting factors. So intrinsic pathway is activated through exposed endothelial collagen, while extrinsic pathway is activated by tissue factor, which is released by endothelial cells. So both the pathways involves activation of the coagulation clotting factors and leading to formation of thrombin followed by fibrinogen match and stabilization of the clot. Any defect in any of the deficiencies of the factor can lead to any bleeding disorders. So there are certain limitations to these mechanisms, like certain factor deficiencies, which means on investigation they have high APTT but may not lead to significant bleedings, or like lupus anticoagulant, in which there is a spuriously high APTT, but they usually manifest with thrombotic complications. So, because of these limitations, a new cell-based model of coagulation cascade was published around 10 years back, in which there are 3 steps: initiation, amplification, and propagation. So, in initiation phase, like the exposed endothelial cell with tissue factor binds to factor 7, and it leads to formation of thrombin, which helps in priming of or amplification of the other factors, leading to formation of large amount of thrombin and resulting in the formation of fibrin, which helps in establishing coagulation. So hemophilia usually presents most commonly with joint bleeds, followed by muscle bleeds or soft tissue bleeds. Joints most common are the large joints. Rarely they may present with small joint pain. So life-threatening complications are like intracranial bleed, abdominal or GI, and even ileocecal bleed, because of a large volume of blood can be accumulated there and leading to life-threatening shock. So, like I mentioned, serious complications are like joint bleed, muscle bleed. Most common is the joint bleed. 70 to 80% of the patient presented with joint bleed. Life-threatening intracranial is less than 5%. 5 to 10% of the patient may present with neck or throat or GI bleed. So there are symptoms of a bleed where like aura in we called aura in hemophilia also, like in hemophilia also bubbling and tingling sensation in the joint or muscle, which is the earliest sign of bleeding in hemophilia, followed by they may develop swelling, pain, tenderness, and warmth, and longer bleeding line may lead to muscle morning stiffness and restriction of the movement. So based on the amount of factor in the blood, they are divided into mild, moderate, and severe. Around 50% of the patients are severe hemophilia, in which factor level is less than 1%, and they present with spontaneous bleeding. They usually diagnosed in first year of the life. Moderate hemophilia, in which the factor concentration factor is 1 to 5%, occasionally present with spontaneous bleeding, but with minor trauma or surgery, they may have prolonged bleeding. Usually diagnosed after 2 years of life. Mild hemophilia constitutes around 30 to 40% of the patients, and factor 8 level or 9 level is 5 to 40%. Rarely have spontaneous bleeding, but severe bleeding may happen with major surgery or trauma. They usually diagnose after 3 to 4 years of age. So coming to diagnosis, the sample required is should be collected in citrate bulb, gently mixed, and immediately transferred for investigations. What WFH recommends is sample should be collected in citrate bulb, sodium citrate bulb of concentration 3.2%, and kept at 18 to 25 degrees centigrade during transport or storage. should be analyzed within 8 hours of collection and 4 hours for factor 8 levels. And if required for further workup, then they can store it deep frozen at minus 35-degree temperature or lower. So on bleeding profile, they have raised APTT because of the affection of the intrinsic pathway. If APTT is raised, then we do mixing studies with normal pooled plasma. If APTT corrects with mixing studies, it suggests that there is deficiency of factors, clotting factors. Then we have to do definitive diagnosis by specific factor assays like factor 8 or factor 9 for hemophilia. Management part, nowadays the factor concentrates are the major chunk in the pharmacological agents. Initially, we were using cryoprecipitates, fresh frozen plasma when factors are not available. And there are certain newer therapies which are involved in management of hemophilia. Along with that, mild hemophilia or von Willebrand factor may be managed with desmopressin, and mild mucocutaneous bleed may be managed with tranexamic acid or aminocaproic acid. So, in early 19th century, the patients of hemophilia were managed with whole blood later with plasma or cryoprecipitates, but because of the high incidence of HIV infection with these blood and blood component therapies, there was then the plasma derived followed by recombinant factors came into picture, and the later extended half-life factors and gene therapy and non-factor therapies are now available nowadays for treatment of hemophilia. So as we see in this slide, fresh frozen plasma, which was initially used as all clotting factors, and it carries around 1 ml of FFP carries 1% of the factor activity. Cryoprecipitates contains factor 8, factor 13 fibrinogen, and von Willebrand factor. And 1 bag of cryoprecipitate contains 70 to 80 units of factor 8. Then plasma derived factor concentrates, it contains factor 8 plus von Willebrand factor, and recombinant factor contains only factor 8. So there is a risk of transfusion transmitted infections with cryoprecipitate fresh frozen plasma and rarely with plasma derived factors, and risk of allergic reactions with these. So the dose for treating hemophilia is 0.5 into weight upon into the desired minus baseline factor level. So 1 unit is the amount of factor present in 1 ml of the normal plasma. The current and desired clotting factors are as per guidelines, we'll discuss later. Half-life of factor 8 is around 12 hours and factor 9 is around 18 to 24 hours. And 1 unit per kg of the factor 8 raises plasma level by 2% and factor 9 by 1%. So this is a busy slide in which they have mentioned the dose of factors in resource constraint and no resource constraint setting. So in no resource constraint setting, life-threatening bleed will require 80 to 100% of the corrections for initial few days, followed by 40 to 60% of the factor. Similarly, for factor 9, in resource constraint settings, around 50 to 80% for life-threatening bleed and 20 to 40% for joint bleeds. So, prophylaxis, which is the standard of care in severe hemophilia patient, the prophylaxis was conceived from the observation that moderate hemophilia patients with clotting factor more than 1 international unit per deciliter seldomly experience spontaneous bleeding and have much better preservation of joint function. This is the idea behind giving prophylaxis, to convert severe hemophilia to mild hemophilia. So there are different protocols like episodic or on-demand therapy, which is factor administration only at the time of bleeding. Then continuous prophylaxis, which is divided into primary, secondary, and tertiary. Primary is when started before second large joint bleed, before 3 years of age, and in absence of joint disease. Secondary is started after more than 2 joint bleeds, but before the onset of joint disease. And tertiary is started after the onset of joint disease. So continuous prophylaxis is factor administration for more than 45 weeks per year, and intermittent is when given for less than 45 weeks per year. So apart from that, there are certain home-based mechanism by which we can prevent the bleeding and like protect or rest the affected joint for 24 to 48 hours, applying ice to reduce swelling and pain. Compress by wrapping it or applying. Just a minute. Crepe bandage over the affected joint and elevate the injured part above the level of heart. Apart from that, there are certain life modifications like to prevent the bleeding, avoid drugs that can affect platelet functions like non-steroidal anti-inflammatory drugs. Paracetamol is safe for analgesia. Regular exercises to promote strong muscles, protect joint and improve fitness. Avoid contact sports. However, swimming and cycling is encouraged to build strong muscles, protect joints, and recognizes early signs of bleeding like tingling sensation or so complications. The most common complication is hemarthrosis because of the repeated joint bleed in the target joint. Target joint is defined as whenever 3 or more than 3 bleeds in the same joint in a span of 6 months. So hemarthrosis is one such complications. The treatment would be to give prophylaxis, tertiary prophylaxis, plus may require orthopedic intervention in stage 3, stage 4, or stage 5 hemarthrosis. The second most dreaded complication is inhibitors. Inhibitors are IgG and allo antibodies against the exogenously administered factors. It is a serious problem. Notice when patient become refractory to factor therapy or increased requirement of factor or no response to factor therapy. Increases the risk of serious bleeding manifestations leading to end-stage joint disease. Patient have severe morbidity and even mortality with inhibitors. Increases the cost of therapy and poor quality of life. So management is immune tolerance induction by giving high dose factor around 200 international unit per kg alternate day to induct immune tolerance. And if there is acute bleed during this period, factor 7 or APCC can be given to reduce the bleed. And certain newer therapies like imicizumab is available also in inhibitor settings. So coming to the prevention part, like genetic assessment, it is mainly for the obligate carrier to identify molecular variant for the possible prenatal diagnosis. All symptomatic females with either lionization or X chromosome inactivations should do genetic assessment. There are certain mutations in which inhibitors development works in hemophilia, then predict the response to ITI therapy and certain means before gene therapy to do genetic assessment. So now moving to the future approaches to hemophilia care, from pre-replacement therapy to replacement, which is on demand or prophylaxis, with standard. We are here now, but there are certain factors with extended half-life by integrating albumin or pegylated factor to increase the half-life so that the prophylaxis can be given easily, like once a week or twice a week. Once a week in hemophilia and twice a week in hemophilia V, with non-replacement therapies like factor VIII mimetics or agonist and antagonist therapy of procoagulants and gene therapy. So in this picture, the most promising agent is imicizumab factor, which is factor VIII mimetics, which works with factor VIII and factor IX to promote kinase complex and followed by establishing coagulation. Then there are certain rebalancing agents like poncizumab, which is tissue factor pathway inhibitor, or fitusiran, which is antithrombin 3 inhibitor. There are certain newer therapies which are under trial, like protein C inhibitor or protein S inhibitors. So like I mentioned, factor VIII half-life extended product, which most of the factors are under clinical trials for hemophilia A. Then imicizumab, which is factor VIII mimetics, rebalancers like small interferon RNA, which is fitusiran, which is antithrombin 3 inhibitor, and concizumab, which is tissue factor pathway inhibitor. All of them are under phase 3 trial, and shown promising results. Then for curating gene therapy, which is also under clinical trials, either like gene editing is also available with CRISPR or Cas9, which is also under trial. Currently not available in India, but we may soon get CMC Vellore gene therapy trials. So when should a pediatrician be concerned that child may have bleeding disorders like bleeding after circumcision? The pediatrician should raise their antenna. Intracranial bleed anytime during infancy, unusual bruising, prolonged or excessive bleeding after invasive procedures, surgery, trauma, prolonged mucocutaneous bleeding, and heavy menstrual bleeding, even in adolescent women, commonly being von Willebrand factor deficiency. So to conclude that bleeding disorder may not always present in neonatal period, it is important to maintain high index of suspicion and keep hereditary bleeding disorders on differentials. Pediatricians are positioned to identify and suspect these disorders first via history examination and family history, and the communication between pediatrician and hematologist is encouraged, and to refer the child to hematologist for further evaluation if required. Thank you.
Well done, Amit.
Very nice. I have a question, Amit.
Yes, ma'am.
That antibodies develop to factor 8. So do they even develop to the recombinant factor 8?
Yes, ma'am. Both plasma derived or recombinant. There is a study called CPET in which they have shown that inhibitors are more common with recombinant. But apart from CPET study, all studies shows it is more common with plasma derived. Most of the factors nowadays available are recombinant only, ma'am.
Okay. But they're available only in the blood bank.
No, ma'am. Not blood bank.
Okay, that's what
It is
I
either available with societies or pharmacies, ma'am. So societies gives free of cost to the patients, ma'am, those who are registered, ma'am. And some hemophilia centers like KEM is one big center in Mumbai. Even in Borivali, we do have factors for hemophilia patients.
KEM has a hemophilia center.
In KEM and even Borivali has
The Borivali Center for Thalassemia. You are
yes,
there?
Yes, ma'am, I'm attached there.
So what days do you go?
Ma'am, daily.
Every day. What time? Yes. So if you have to refer a child?
Ma'am, 9 to 4, ma'am.
9 to 4?
Yes, ma'am. Ma'am, I'm attached full time there, ma'am.
Oh, okay. Okay. How nice to know that, Amit. So that's not, Borivali Center is not just for thalassemia, it's for all kinds
Ma'am, yes, ma'am. All blood related disorders, hematology, oncology, and bone marrow transplant.
So suppose we want factor 8, then we will get it at, we have to send the patient there?
You have to send the patient, ma'am.
Correct. Okay.
Ma'am, we are not giving prophylaxis currently, ma'am, because of shortage of factors during Corona, ma'am. Actually, factors are coming from abroad. So there is significant deficiency even in KEM. But KEM is one such center where most of the times factors are available.
Okay. And Amit, that Borivali Center is HPLC done free of cost? If it
Yes, ma'am. Free of cost, ma'am.
How
you can
many
refer.
patients can you do? Suppose we send.
Ma'am, you can refer a number of patients. Ma'am. We are doing screening for all the patients who are come for even for oncology and where we suspect there could be thalassemia minor. We are doing free of cost, ma'am.
So do you all do any camps or anything? Suppose we want to do a camp.
So, ma'am, before Corona, ma'am, we were doing with Mr. Vinay Shetty, ma'am. And now we are planning.
Vinay Shetty is very interesting. We'll like to have his number.
Ma'am, he is must-see for thalassemia patients, ma'am. Every thalassemia patient is aware of Mr. Vinay Shetty, ma'am. He arranged, yes, ma'am. He arranged blood for any patient, ma'am. Just one call and he can arrange, ma'am.
Super.
So what is the cost of these factors? For sitting, like how much do they cost?
So, ma'am, when we have to purchase, it is, ma'am, 8 to 10 rupees per unit, ma'am.
Okay. And at the sitting,
it's quite costly, ma'am.
Okay.
So,
and
most of the, Yes, ma'am.
One more question, ma'am. Sir, how do you counsel the girls with hemophilia? How do they manage their menses? What do you give? Are they told to
So-
take something prophylactically? How,
So,
how
ma'am,
do you, how are
actually,
the, yeah.
actually, hemophilia is X-linked recessive, ma'am. Very rarely they manifest with, ma'am, bleeding manifestations when either with lionization or X chromosome inactivation. So some women may have mild hemophilia because of carrier status, ma'am. 40 to 60% of the factor, 40 to 60 international unit, ma'am, factors. But rarely they manifest with, ma'am, bleeding manifestations. Just, ma'am, if they are carrier, they should be known that so that we can do antenatal testing before the delivery of the child, so that the male child being prevented by the hemophilia disease.
So that factor A concentrate will also be useful for factor 9 deficiency, or it's only
So, ma'am, factor 9 is also available, ma'am.
okay.
Factor 8, factor 9 are separate, ma'am.
Okay.
But with factor 9, there are increased chances of anaphylaxis or anamnestic reactions, ma'am. And inhibitors are less common with factor 9.
And for Willebrand, we give them factor 8.
So, ma'am, for von Willebrand, as per ma'am, means only von Willebrand factor is not available in most of the centers. So, impure factor 8 concentrates, ma'am, in which plasma derived factor 8s, in which there is von Willebrand factor. So, we do give.
You can give plasma derived. And
Yes, ma'am.
for you can give them cryoprecipitate.
So, ma'am, currently better to avoid cryoprecipitates, ma'am, since factors are available, and all hemophilic patients are aware of the factor therapy in Mumbai, ma'am. So they can arrange with hemophilia societies, or they are aware that where factors are available, they can go. But in life-threatening situation when factors are not available, you can give cryoprecipitates or FFP. But cryo for a factor 8 and FFP for factor 9, because cryo does not have factor 9.
Okay. Nice.
So you gave us a list of the when to suspect thalassemia in children for pediatricians. So I would like to share a case which I had seen almost 13 to 14 years back. This was a day one newborn baby, and it was a full-term normal delivery with vacuum, which was in the night. And morning I received a call stating that the baby looks absolutely pale, and so we shifted the baby to the NICU and thought it is a massive kefal causing a hemoglobin of 4. We started him on, I collected investigations, gave him Paxils twice, thrice, 4 times, but the hemoglobin persists to be 5 to 6. Then I thought maybe he's having, and the swelling in the head continues to increase. That means the bleeding was not stopping at all. So then 13 years back, with our difficult it was, so I mobilized FFP. Dr. Barrett will be knowing this case because he was helping me out with that case. We gave FFP twice, and again this bleeding continued for 48 hours almost. After that, which it stopped, and the hemoglobin rose to 10 to 12. And since then we had transfused the baby, then we had to wait for 3 to 4 months to go to a diagnosis, and then he was referred to a hematologist, and he turned out to be a factor 8 deficiency. So this also was one of the presentation of hemophilia which I got to see in my practice.
In unit.
Yeah. In the newborn, day one baby.
Yes, ma'am. Factor means if a male child with some bleeding manifestations, most common is factor 8 deficiency.
Yes.
But in the setting of consanguinity, or female child or male child, but in consanguinity, other causes could be possible, like factor 7, factor 13, afibrinogenemia. They are more common with consanguinous.
I had seen one child 40 years ago when I was doing my residency, and this child was a newborn. And when the cord, there was a delayed fall of the cord, and when the cord fell off, there was from the cord. And all the normal tests were negative for any of the bleeding disorders, and that child turned out to have factor 13 deficiency.
Factor 13 deficiency of normal PTA, PTT, but 5 molar osmolar clot stabilization test is abnormal.
Yes. So then they had to do that test. I forgot also which test, but only I remember that there was delayed cord fall, and there was this cord bleeding. That time. So very, very illuminating, Amit. And can you share the PDF of your presentation?
Yes, ma'am. Sure.
Save it on our Facebook and we can refer. Of course, we will do 3, 4, and 5, and you will be called for every child, but
Sure,
it's
ma'am.
for our reference so that
Yes, yes.
there is some knowledge and we know what is happening. So if you can, and we'll request even Ruchira to share her PDF. We don't want a slide share so that we won't use the same slides and we will not be even eligible to talk anything about hemophilia, having seen just one factor 13, 40 years ago. So, but we would certainly like to go through all your well-prepared slides.
Sure.
Amit does attend calls.
Yes, yes.
Attend calls.
Indrajit, anything more to say? Any more questions?
Any more questions from anyone would like to ask any more questions?
What is the policy? So you said access for all in partnership policy and progress. So what are all these things? What is partnership?
Partnership means engaging government, ma'am. Government to engage government in hemophilia, ma'am, and for like creating policies for hemophilia and other bleeding disorders. So policy engagement of government is partnership, and access and equitable care is progress, ma'am, for hemophilia.
Okay, very nice. So this also, again, to reiterate what I was saying is that Maha IAP is planned as well as for THAL. And now that we know Amit is working with the Borivali Center for THAL, that's so good for us. And if you can just let us know about any screening program that you'll have, or a screening camp, if we can have it in Vasai Virar area and the samples can come to Borivali Center. Since you are doing the HB electrophoresis, perhaps we can choose a small cohort of patients, only relatives of those with thalassemia or sickle. We can screen them first. So if we can decide on whom to screen, then perhaps if Borivali Center can coordinate, so we'll be happy. And also if you all have any regular screening programs for thalassemia, then we'll be very happy. And I'm happy that Jagdish also spoke about the Hanu and Jawahar centers which are doing this regular screening with HPLC.
Yes.
Also find out from our district health officer where in Vasai Virar and other Palghar areas this is available, so that we can do more testing and screening of our pregnant mothers, so that we can detect this, or even adolescent girls, especially those with anemia, we can do. So this is the plan for detection of thalassemia very early. Treatment is something that is so morbid and we should try and eradicate.
Actually, ICMR was doing, ma'am, for sickle cell anemia, ma'am. I'm not sure whether they are doing now also, but they were doing sickle camps in Dahanu and Palghar.
But how can they do only sickle test? So is there a special sickle test, or
Actually they were doing sickling studies first, and if sickling comes positive, then later HPLC.
electrophoresis?
In tie-up with NIH. So they had referred them certain few patients from Dahanu and Palghar district.
Because there is such a big belt, and now there are so many migrants, and there's so much movement of population, that I think it will be difficult to say that it's there only in Jawahar or in Dahanu. I think there are Palghar also, there in Vasai also there are so many people who have come from those areas. So I think testing for all is needed.
Now it is not limited to certain communities or places.
Yes.
Everywhere.
Especially places. We are going to have a talk on sickle cell also. Jayashree was saying. So Jayashree, you'd like to mention that?
Dr. Dipti Jain is working on sickle cell disease, and they are working in Amravati Melghat, where the pocket is maximum, and even near Nagpur also. So she will be there to talk on sickle cell disease and the government policies regarding sickle cell disease or the ICMR project. She will
On
be
8th
talking
of
on
June.
8th of June. Yeah. So, Dr. Amit, we would like your inputs also in that meeting.
Sure.
Because she's also Jain and you're also Jain. It's Dipti Jain, so we want Amit Jain there.
Jain, yeah.
Yes, ma'am. Sure, ma'am.
Jain bina chain kaha. Now I'm picking up Hemant Joshi's role.
तुमचं म्हणजे absence तुम्हाला वाटायला नको म्हणून शी इज टेकिंग ओव्हर या
Yeah.
तो
Archana.
डॉक्टर हेमंत जोशींची आठवण मॅडम सगळ्यांना येते बघा
Jain bina chain kaha. So Jain has to be there when Dipti Jain comes.
Yes, ma'am. Yes, ma'am.
And Shailesh has nothing to say for that.
शैलेश आय लाईक युअर ड्रीम हा इट्स व्हेरी मच निडेड अँड किती वर्ष झाले आम्ही वाट बघतोय ब्लड बँकेची
तो
अशा
विरारचा धीरूभाई अंबानी आहे ड्रीम बिग. Dr. Anant Kulkarni is the CEO of Kaman PHC. Dr. Anant Kulkarni, you'd like to say something about the incidence of in the Adivasi population at Kaman?
Yes, ma'am. We had said that government also run some camps. Yes, ma'am. There are some camps. I think in September there is the sickle cell week in the government run rural centers, and we do daily testing at these days. In these camps are arranged in the rural schools, and we do sickle cell testing of all the students in these rural schools.
So have you found a high incidence? What is the incidence have you found there?
Ma'am, in our population of 30, 40, 50,000, we found 2, 3, 4 tests positive, sickle cell positive.
What about thalassemia? Are you all testing for thalassemia regularly?
No, ma'am, we are not having any facility of thalassemia.
Yeah, so that is what I thought, that we should have this HB electrophoresis, and if there is any facility for that, then we'll be so well put to know what is the incidence of thal. And do you all see thalassemia in children there?
Yes, ma'am, but we refer it to SDH Dahanu or Jawar if
so
symptomatic patient.
So Dahanu Jawar is about 100 kilometers from where you are at Kaman. So far a patient has to travel. So
otherwise, we refer to Mumbai centers like KM or JJ.
So you have a center at Borivali now, Dr. Anand. Dr. Amit Jain works there. So there is a center at Borivali also.
Yes, ma'am.
It's run
I
by
have some very important information. Thank you.
Yeah, so they have it at, it's very close to Borivali station, and it's run by the Borivali, by the Mumbai Municipal Corporation along with the Tata Trust. So I think it's very, very good. It's a very good center. You have very good hematologists like Dr. Amit Jain, Dr. Mamta Manglani was the mentor there. And I think even Dr. Ratna Shah is...
Ratna Sharma.
Ratna Sharma is there. So there are lots of very good doctors available, hematologists, very committed. So, like Dr. Amit says, he's there between 9 and 4 a.m. So 9 a.m. to 4 p.m. So that's so nice for us to know.
Dr. Amit Jain also visits Dr. Joshi's hospital. Madam, तुमच्याकडे येतात ना?
And
he's very helpful in every case. Wherever even we SMS him, he will answer you always. So thank you so much. Yeah.
Thank you so much, Amit.
I'm so